Welcome to the conference session titled GVHD. Thank you for joining us. My name is Alice Hauk. I'm the Senior Director of Patient and Professional Programs at AAMD-SIF. As we get started, we'd like to recognize the generosity of our corporate sponsors, the Diamond level sponsors, Alexion and Novartis, Gold level sponsor Apellis and Genentech, and the generous support of patients, families, and caregivers for supporting our conference today. Immediately following the presentation, there will be a question and answer session. When asking questions, please wait for the microphone so everyone can hear the questions you're asking. When asking questions, please do not share private health information in your question. The speaker cannot answer any specific questions regarding your health care. Today's specialist is Dr. Pashna Munshi. Dr. Munshi is the Associate Professor of Clinical Medicine and Hematology and Oncology and CTT Leader for Quality and Safety Transplant Program at the University of Pennsylvania. She is a board-certified physician in hematology, internal medicine, and medical oncology. With that said, it's my pleasure to welcome Dr. Munshi.
Thank you all so much. And I'm going to do my best to keep you all motivated to learn something about something that's not very easily treatable, but it's a man-made problem. We do our best, and I know it can be scary and overwhelming, but I'm going to do my best to make it not so scary and interesting and something to learn about, and end with some resources for you all to, in the survivorship space. And thank you for bearing with us to the end. I have no relevant disclosures. And some of the data that I may present here, and there's probably just about 2 abstracts, are not yet published in a peer-reviewed journal. So we always have to give you a bit of disclosure about that. Okay, so I'll start by just giving you a little bit knowledge about transplant that Dr. Hussain did a great job. He's given you an introduction about the transplant and how it's used to help cure MDS. Now, when I'm talking about transplant here, we're only going to be referring to a donor transplant known as an allogenic stem cell transplant. And in that setting, it causes a lot of complications. Nothing that we do in medicine is without risks. And so we kind of categorize these risks in early and late forms. And you can see that there's a long list of, complications that can happen over time in the lifetime of that patient. But today's talk, our focus is graft versus host disease. And so that's where I'm going to take you. But before we get into that, most people really I find that they struggle with the concepts of what is a transplant. And oftentimes my patients will come and say, is this a surgery? And so I like to start with setting the stage that let's talk about surgery then, okay? Let's talk about a transplanted organ. And you're more familiar with kidney transplants, you're more familiar with liver transplants, maybe you know somebody who's gone through it. So think about somebody who has a healthy immune system, whose organ is not functioning, the kidney has failed, and now they've gotten a transplanted organ. And now you've put this transplanted organ into the body where somebody's immune system says, aha, why is there a new kidney in this body? You're not supposed to be here. I don't recognize you. And they have this God-given talent to attack. And that's what the immune system does. When it doesn't recognize something that's meant to be in the body, like an infection or a virus or even cancer, it's supposed to attack and it's supposed to kill this off. And so that's exactly what it does. It kills off the kidney, and that's called rejection. In order to prevent that, patients are put on lifetime immune suppression to prevent the immune system from recognizing this organ as foreign and preventing this rejection. So that immune suppression is taken for the life of that patient. Now, reverse that and think about somebody in this room, maybe somebody in another room, patients with leukemia, patients with MDS. They don't have a healthy immune system, and that is what's causing their cancer. And that's why we have to transplant their immune system. So in this case, the transplanted organ is the immune system coming from a donor, a healthy young donor with a healthy young immune system, again, with that beautiful God-given talent to attack everything that it doesn't recognize as foreign, and in this setting, cancer. And that's called the graft versus leukemia effect. So here we are transplanting this immune system into our patients. Patients have healthy organs otherwise. Their liver is otherwise generally healthy. Their skin is healthy. Their gut is healthy. And we're putting this new immune system there. And all that that does is it goes straight into these immune systems and causes a reaction almost attacking them, called graft versus host disease. So that's just the initial stage setting of trying to understand what's happening here. So as much as we like not to have GVHD, most of our patients will get GVHD. GVHD is what I'm going to say now instead of saying the whole nomenclature of graft versus host disease. So again, our patients are put on immune suppression as well, but more about that later. However, it's not just so easy. You know, this is very complex. There's a lot of interplay that happens with the graft. And I've tried to simplify it here with this very elegant study that, even though it's all done in 1990s by Mary Horowitz and her colleagues, it still holds true to today. It's really finding that really amazing fine zen and balance between an active graft or the donor immune cells that does what it's supposed to do, fight the cancer, but not cause high-grade GVHD. Because when you have too much of GVHD, the patients don't feel so well and they do poorly. So that's why you have this yin and yang balance that we all try to achieve as transplant physicians. And on the right, you can see that the blue bars is how we grade GVHD. It goes from, you know, low grade, like grade 1, to high grade, grade 4. And as you have high grade GVHD 3 and 4, the green bars you can see on the top, it flips with grade 3 and 4. It actually heralds treatment failure, because high grade GVHD has a lot of complications of infection, poor quality of life, and ultimately treatment failure. But we do need the graft, and we do need some GVHD. And this is, again, the same study that very elegantly shows you that patients who had some degree of graft versus host disease, both acute and chronic, as you can see by that little green bars at the bottom, the green line, had better graft versus leukemia effect, and therefore the probability of relapse was the lowest. And so if you go higher up and you can see the black line, this was a transplant by twins. So if they're identical donors, they have a higher risk of relapse, because it's essentially the same immune system as the recipient, which sort of doesn't work. In another setting, there's something called T-cell depletion, where we take the donor stem cells and then we manipulate them and remove the T lymphocytes. And that is done very elegantly in pediatric transplants. We're not using that as standard practice in adult transplants, even though it's done. But that has a higher risk of relapse, because it doesn't have the oomph that you need in the graft to kill off the leukemia. So this is essential. We do need some GVHD, but not a whole lot. Now, we follow our patients in our practice for their lifetime. And as frustrating as it may sound, it's because in the early stages, we look for acute graft versus host disease, but later on in their life, we look for something called chronic graft versus host disease. And typically that can happen anytime in the lifetime of the patient. It's very subtle. The pathophysiology of both acute and chronic GVHD are very, very different. Acute GVHD is driven by essentially angry donor T cells. They're very, very sensitive. They're alloreactive is the word we use, and they just go in there and attack. While chronic graft versus host disease is later on, the body begins to produce antibodies to its own recipient tissues. And that is what causes ultimately fibrosis and the sequelae of chronic GVHD. And the three organs that are essentially involved in acute GVHD are very distinct, while chronic GVHD affects all organs. So that is the essential difference. So let me take you through what happens at a cellular level, as easy as I can to make this for you. because it looks like a complicated picture here. But let's just start with a recipient who gets chemotherapy. Okay, so they get chemotherapy or they get radiation. We call this conditioning regimens. That's the word we use, where the patient has to get this degree of chemo and or radiation to wipe out their own immune system. And sometimes if it's high doses, it even helps wipe out some residual cancer. And in doing so, essentially, it's already caused the first damage to the organs in the patient. It's I'll show that again in a picture going down the road. But it does that with disease initiation. There's release of something called pathogen-associated molecular pattern, damage-associated molecular pattern, so PAMPs and DAMPs. And it releases a lot of cytokines, a lot of reactive cells that further trigger something called the antigen-presenting cell. Once that's triggered, there's a cascade of events that happens. It goes into phase 2 of the pathway of acute GVHD, where the donor T cell now gets activated, excited, and directly attacks the organ. And on the bottom right, you can see it can end up being a cyclical pattern if you don't step in there and treat this right away. So these are the 3 big organs that get affected with acute graft versus host disease. As you can imagine, when somebody gets radiation or they get chemotherapy, the skin gets affected right away. The gut gets affected right away because these are actively dividing cells. Any cells that are actively dividing are damaged right away by chemotherapy and radiation. So that's where already the barrier is disturbed, and all those cells are then exposed to the incoming transplant donor T cells. And so when GVHD happens on the skin, people can get this angry red rash. It can happen in the whole body. It can even happen on the palms and soles. The liver can get damaged, and people can get a high bilirubin. They can have jaundice. And on the top right is what's happening in the intestines. This is very pathognomic, where the intestine mucosa, we call this the loss of Cripps or villus blunting, it's just shed off, and people have diarrhea, and sometimes that diarrhea can be uncontrolled. But there are many, many factors that participate in causing graft versus host disease, right? So it's essential that we find a good degree of match. It's essential that we think about the age of the donor, the disparity, gender disparity sometimes also can have an implication in acute GVHD. And as I mentioned, it's the conditioning regimen, the high intensity chemotherapy versus the more reduced intensity. All these factors, whether the graft is coming from the peripheral blood, whether it's coming from the bone marrow, do impact the risk of GVHD, whether they're at higher risk versus lower risk. And these days, we have more research and more data where we have biomarkers, and I'm not going to get into that here. But there are, in essence, we can sometimes predict who may get more GVHD than others. All right, this looks really confusing, but I don't want you to really pay attention to all the lines going helter-skelter, but this is just to show you very simply, it's even more complex than this, that what's happening in the gut of the patient. This is the gut epithelium on the top, that's the cells, and they've been damaged by the chemotherapy the patient's gotten. And initially, that first damage begins to now send a cascade of reaction. And that's what's essentially the pathway to acute GVHD. It's so complex, right? And we're just learning about these pathways. And where you see the little blue boxes is where there are drugs where we can target some of these pathways and prevent graft versus host disease and even treat graft versus host disease. So this is just to give you an idea of how many interactions happen. And sometimes one drug doesn't do the trick, because if you just hit one pathway, the other pathway is still active and continuing to destroy the gut. So once the gut gets destroyed, the other aspect of this is the microbiome. I don't know if you've heard this word. The microbiome is essentially the bacteria that live in our gut, that have a home in our gut. They are called commensal bacteria. They're healthy bacteria, lactobacillus, and everybody takes probiotics and prebiotics. You probably heard about a lot of this on television or in with Dr. Oz and all these other physicians who come up and speak about this. But it's true. I mean, and we're finding that there are lots of data out there and more research that has been done on the microbiome and how it's relative to cause cancer, it's relative to cause disease, and it also potentially impacts graft versus host disease, because when the gut is destroyed, it flips the degree of good bacteria ratio with the bad bacteria, and the pathogenic bacteria increase, and that further activates the antigen-presenting cells that recognize these pathogens, try to get rid of them, and further activates those donor T cells to come and get rid of these bacteria. But instead, they're also attacking the healthy gut. So we have current approaches now to prevent graft versus host disease, acute graft versus host disease. We can start right at the beginning, at the conditioning tissue damage, where there's dysregulation of the microbiome. There are trials where we've tried probiotics on patients. We can start at the donor graft level. At the bottom there, before the donor graft goes in, you can do T cell depletion. You can do something called CD34 selection. The T cell depletion is just essentially removing those angry T cells from the graft and giving pure stem cells to the donor, to the recipient, excuse me. And so those are some of the things we can do. The other aspect is once the donor T cells go in, we can give a drug called cyclophosphamide to prevent those donor T cells from expanding. They're called the cytotoxic T cells. So we don't like cytotoxic T cells. They get the cyclophosphamide essentially eradicates them and allows the healthy regulatory T cells to then grow. And this is the backbone of a lot of transplants these days. It's called PTCy. You may have heard some physicians speak of it. It's called post-transplant cyclophosphamide. So this is one of the big transplants that everyone is doing across the country mostly. There are lots of other activation pathways that we can target. Once those cells go in, we can give regulatory T cells. We put our patients sometimes on even photophoresis if they do have active GVHD, etc. So I wanted to just give you a summary of targets. It can be very heavy to understand all the different pathways that we try and target. But one of the novel pathways that I would like you to remember is something called the JAK inhibitor, the JAK-STAT pathway. And I'm going to show you some data on some of the drugs that are approved to treat acute GVHD as well as chronic GVHD, and that's called ruxolitinib. So let me see if I can point out with my pointer here. Where is it? I have to... this one here. Is it doing anything? I don't think so. No. So this is the JAK inhibitors here. Okay. And that's the T cell JAK-STAT pathway here. And then there is something called abatacept, which is also a drug that was recently approved in the setting to prevent GVHD for mismatched transplants, meaning if the donor and the recipient don't have a fully typed HLA that matches. So I'm going to show you some of that as well. And there are other drugs that can block trafficking to the intestines called vedolizumab. It's not approved, but we use for GVHD, but we have used it. I've used it in my patients with some success. And then there's also, when GVHD is really, really severe, we've done fecal microbiota transplant, which is essentially giving. Oh, it's gone off. I'm sorry. Oh, okay. Should I maybe try and turn this? Okay, so sorry about that. So the fecal microbiota transplant is essentially trying to replace the patient's unhealthy microbiome with a healthy microbiome. It's done in dramatic cases. And then there are lots of other immune modulators like alpha-1 antitrypsin, mesenchymal stromal cells. These are all research driven. Okay. Here is, I had mentioned something called CD34 selected stem cells. I just wanted to show you this data because it's really wonderful to see the degree of lack of GVHD when you can deplete the graft of the T cells, because you know the patients get a stem cell graft that's very complex. It has pure stem cells, and then it has T cells, it has NK cells. There are lots of other cells that go into the patient. And oftentimes we just don't segregate these cells when we give them to the recipient. But in some instances, and some centers do this, where they can segregate the cells and give pure stem cells back to the patient. And that's called a T cell, a CD34 selected graft. And so on the left, you can see that with the blue dotted line is T cell depletion, that the grade 2 to 4 acute GVHD was very, very low, as well as chronic GVHD. Those blue lines, when they're that low, it just means that it's a very low rate of GVHD. Okay, so coming to some of the drugs, actually. Now, I mentioned abatacept is the drug that was recently approved in some particular settings. It's also used in the pediatric setting for 2 years and older who had an allo transplant from a matched unrelated donor. That means it's not a related donor that's come from a donor registry, or mismatched, incompletely matched donor. So they're not fully matched. They have high risk of GVHD. So what this study showed, that they looked at the acute GVHD-free survival rate at day 180 after transplant. So that's around 6 months. And it was 50% for those who got abatacept compared to 32% who didn't get abatacept or got a placebo. So that's a significant difference. So that led to the FDA approval. There was also a GVHD2 trial. This was a registry trial. Here, they looked at basically mismatched MUDs again, 7 out of 8, meaning they're not fully matched. 8 out of 8 would be fully matched. And these were patients who got standard immune suppression, which is tacrolimus and methotrexate with abatacept versus tacrolimus methotrexate alone. And again, there was improved overall survival at day 180 with abatacept. So this is a drug that can be used. It's exciting to have these things available when previously we didn't have this option. This is probably really tiny to see on your screen over there. Oh, it's back up. Excellent. Can I turn this? Maybe let's just keep that there in case it happens again. It's a little tiny for me rather. But what I want to show you on the left is an algorithm. This was recently published by Betty Hamilton. And it's she sort of elegantly talks about how she approaches and to treat and prevent GVHD after an allo transplant. There is something called risk stratification, meaning, you know, I talked to you about how we can sometimes predict who may get GVHD, but once they get GVHD, we also know how to score them. And this is important because we need to understand how severe is this GVHD. Because when we treat it, we need to see if the severity decreases, or if it's really severe, we can even predict overall prognosis. So on the right is something called the MAGIC score, or the MAGIC Consortium. This was through the Mount Sinai Acute GVHD International Consortium, where they put together the degree and intensity of tissue damage in the skin, in the gut, and in the liver. And based on that, it spits out a score. And based on that score, it spits out a total grade. And sometimes people can have rash and they can have diarrhea. So how do you grade that? And what degree of diarrhea? So this helps us as clinicians what's going on with the patient and how to treat it. So first is to risk stratify. And if they're considered, you know, based on this biomarker assessment standard risk, then you consider treating them with standard methylprednisolone, which is generally 1 milligram per kilogram per day. Or you can even offer them a steroid-sparing clinical trial. However, if they're categorized as high risk based on this biomarker assessment, then you can increase your dose of prednisone to double 2 milligrams per kilogram per day. But always we have to keep in mind that GVHD is just like cancer. Sometimes cancer responds to treatments and sometimes it doesn't, right? And that's why relapses happen. So GVHD is like that. It can sometimes respond to steroids, but about 40% of the time, maybe 30% of the time, it won't respond to steroids. And that's called steroid refractory, meaning patients, even after having these high doses of steroids, and by the third day, they still have progression of the disease, or by the seventh day, their symptoms haven't gone away. So if that's the case, then we really need to act very quickly into second-line therapy. So that's where I'm going to take you next. And this was the REACH-2 trial. This was the pivotal trial that led to the approval of a drug called ruxolitinib for steroid refractory acute GVHD. And this is a great drug because it's already approved for myelofibrosis. It's used in some settings in other trials for other conditions. But it essentially inhibits the JAK inhibitor through that JAK-STAT pathway that I had initially pointed out. And this trial was a phase 3 trial, which means that it is a randomized trial. It enrolled many, many patients. And this is a huge deal for people with GVHD because we never, ever have phase 3 trials for GVHD because it's very hard to accrue these patients on clinical trials. It's very hard to distinguish the types of GVHD they have, the grades. So this is a huge effort and it's marvelous. So patients here on this trial got ruxolitinib 10 milligrams twice a day. Remember, they were all steroid refractory, which means they had either a liver that was poorly functioning, they had a lot of skin rash, or they had diarrhea that was not getting better on steroids. Or they got whatever the physician chose to give them. So they got ruxolitinib or they got best available therapy with the steroids. And the study wanted to essentially look at the overall response rates at day 28 and then whether this was durable at day 56. Essentially, I should have had a slide here, one more to show you the data. But it was FDA approved and it essentially showed an improvement in about or more than 50% in patients who didn't get, compared to those who didn't get ruxolitinib. So this was great. And then we're also now using ruxolitinib to try and prevent acute GVHD. This is not yet approved, but there are a lot of trials out there that are looking at this specifically in myelofibrosis patients, because it's a drug that's already used in myelofibrosis. And this is a study that was published in Blood. This is an abstract. So again, I don't have the full data here, but essentially, these were 48 patients who were accrued within 1 year. And the primary endpoint was to look at how many patients were free of GVHD and free of relapse. So this is an endpoint called Griffiths, or GVHD-free relapse-free survival. And they have 58% of these patients with myelofibrosis had JAK2, 12% had different mutational status. And at 1 year, 65% of patients were alive without GVHD and without relapse. So this is, again, a very, very exciting number. Of course, it's not 100%. A lot of times studies at 1 year, this is premature data. We still want longer data. Sometimes survival data needs to be spread out even longer. But you can see that the overall survival was 77%. And the cumulative incidence of non-relapse mortality, meaning patients who basically were alive without disease, without relapse, was 13%, which is low. So this is considered a good thing because you don't want mortality. You don't want people dying of the complication of transplant. So non-relapse mortality means people who die outside of their disease. And that's low. So again, we are using ruxolitinib in many forms here, but we're talking about acute GVHD. So with that, I'm going to take a segue into chronic GVHD because this becomes part and parcel of survivorship for patients who have had a transplant, they're living disease-free, but they may have some side effects of the transplant. So this is chronic GVHD. All right, so that's gone again. Once again, just like acute GVHD, this goes through phases. Now, the phase 1 is already the incriminating factor, which is the acute GVHD that this patients may have had. It starts with the conditioning regimen. It starts with the stimulation of, irritants in the gut and the skin. And it all starts with the thymus, which essentially lives somewhere between your thyroid and your chest here. And in the thymus is responsible for producing your healthy T cells and producing essentially a pathway to make antibodies in your blood for the rest of your life. So these antibodies understand the environment and they protect you from the environment. So once acute GVHD has set in, even if it's gone away, the T cells and the B cells now get stimulated. So in chronic GVHD, we have other cells called B lymphocytes that are stimulated through the thymus, and they cause autoantibody production. And then that goes into phase 3. The autoantibodies stimulate something called the macrophages. And the macrophages are essentially cells that protect you with humoral immunity. They get excited, they have monocytes, and then all that gets differentiated, and essentially they cause fibrosis in the body. And that is what happens with chronic GVHD when there's scarring. And that's very difficult to reverse. Think of if you've had a skin injury and you've now got a scar that, it's hard to get rid of that scar after. It takes years and years for that scar to fade. So that's what happens at even the molecular level. It happens in the patient's body, in their tissues, where there's just a scarring that can happen in the lungs. There's scarring that can happen in their skin, and the skin can become tight and fibrotic. It can affect the eyes. The eyes can become dry, affect the mouth. The mouth can become dry. So this is a whole pathway that gets dysregulated. So the macrophages are the big problem here, and they are stimulated by a receptor called CSF1R, which is colony stimulating factor 1 receptor. And we have now targets in clinical trial to prevent this from happening. So these blue boxes are essentially pathways which we can block to prevent chronic GVHD. So in the phase 2, where there is T and B cell dysregulation, you have drugs, again, like ruxolitinib over there that blocks the JAK-STAT pathway. It's in the middle of that big orange cell called the B cell there. There's ibrutinib, which is also approved, which targets something called the BTK pathway. This was one of the first drugs that was approved for steroid refractory chronic GVHD. We've used other drugs called bortezomib, which is a myeloma drug, essentially, or you may know it as Velcade. And then there are other drugs called belumosudil, which was recently approved. So I'm just going to show you some of the pivotal data for some of these drugs to understand. So that's the CSF1 blockade. That's where that 1 star went up. So I'm going to talk to you about axatilimab, which is under clinical trial, which blocks that pathway and blocks macrophage stimulation. I'm going to talk to you a little again about ruxolitinib and show you briefly the REACH3 data that led to its approval. And then I'm going to tell you about belumosudil through the Rho kinase pathway. That's what gets blocked, okay? So again, this is a cyclical pattern. If we don't figure out our patients are suffering from GVHD and we don't stop it, it becomes an ongoing process that doesn't have a turn-off switch, because once fibrosis lays down, it stimulates more cells to lay down more fibrosis, and then the cycle continues. In chronic GVHD, I mentioned many different organs can be involved. This is just to show you, I know this is very tiny. I try to put it all in one slide, but some of these things can be very subtle. For example, you have patients who are essentially doing well. They are going about in their jobs, but when they don't, they haven't really tied their shoelaces because they're not really wearing shoes with shoelaces, so they haven't bent down. They're functioning okay, they're walking okay, but suddenly they decide they needed, the cookies from the top jar in their kitchen cabinet, and they reach out to get them, and they feel tightness in the shoulder. And they hadn't realized that this was there before, because otherwise they haven't used their body in that way. And if they let that go and they're like, oh, it's just a subtle tightness, that tightness becomes more and more and more until we realize that this is chronic GVHD. So it starts off very subtly. Oh, my eyes are a little gritty. It might be allergy. I just have a dry mouth, or you go to the dentist and you've never had cavities, and now you're developing more and more cavities because there's not enough saliva production. So these are things that we know what to look for, and we try and teach our patients to also be aware of some of these signs. And that's why we follow our patients very regularly in our clinics long after they've had their transplant. So we send them to our survivorship clinics, and because GVHD can come anytime. Think of the immune system as an active living thing for the rest of that patient's life, and it's transplanted from a healthy donor. Even if the patients are off immune suppression, anytime they get an infection, anytime they get sick, that immune system's triggered, right, to fight the infection. And in doing so, it has this collateral damage to the other tissues. And so that's why chronic GVHD can happen anytime. So on the bottom right is a patient essentially who has chronic GVHD of the musculoskeletal system, where she's not able to do the prayer sign. This is one of the signs we ask our patients to do in our clinic to see their mobility at their wrist and their elbow. So you can see her fingers are curling up. The nails can be affected. People can have brittle nails. People can have lots of nail falling off. We look at the nails and the hair, and then they have very specific skin changes. So we have our dermatologists also involved. And so there's a whole list of things that can happen. There is a scoring system that we also have to be mindful of. We need to understand how severe is our patient's GVHD. Mild GVHD doesn't really require a whole lot of treatment, but once it becomes moderate to severe, then patients do need treatment. And essentially, these treatments take long time to take effect. And so patients are on prolonged immune suppression, which puts them at risk for infection, et cetera. So we follow the grading system score. It's called the NIH Consensus Conference for Staging of Chronic GVHD, and that's what we use in our clinics. This is, again, a really nice update from the NIH Health. This is the National Institutes of Health Consensus Development Project for criteria on clinical trials in chronic graft versus host disease. And this was recently updated and this in 2014. And this is now the 2020 Clinical Implementation and Early Diagnosis Working Group. Essentially, what they're asking us to do is to get a baseline function for our patients right at the beginning. Because if our patients already have arthritis, or they're not using their shoulder, or they have a frozen shoulder before transplant, we know that that already is immobile, and that shoulder may have a higher risk of developing GVHD just because there's inflammation there already. There's chronic inflammation there. So when those donor T cells go in, they are already there attacking something that's not doing so well. So knowing what's happening with your patient at baseline helps us predict or look for things in the future. So that's essentially what this implementation consensus development project is asking us to do as clinicians. There's also the NIH consensus project giving us guidelines on how to treat patients with chronic GVHD, because it's complex and there are nuances to this. There are many different flavors. And so, again, when you think of local symptoms, if somebody just has dry eyes, dry mouth, we try to not put them on systemic immune suppression, because that is maybe overkill. Maybe they can just do with an oral rinse. Maybe they can just do eye drops. We send them to the ophthalmologist, the dentist, etc. So those are called local symptoms. But once they have 2 or more organs involved, there is a risk that if we didn't put them on systemic therapy, that more and more organs will get involved. And so this is something that we make a decision based on our expertise in the clinic. The initial starting dose is always steroids at 1 milligram per kilogram usually, and we try and taper that slowly. And I showed you that picture with so many pathways that are involved in causing GVHD, and that's why we never just give steroids as a single agent. We always try to do other things in addition to steroids so we can get our patients off steroids, because ultimately steroids are bad for you, right? They're sometimes good for the disease, but they're bad for the patient in the large scale. Then there are the salvage regimens. There are many, many other treatments that have been tried, but they probably have a 30 to 40% response rate, except for ruxolitinib and belumosudil, which seem to be more promising, and I'll show you that. The NCCN guidelines, again, is important because for reimbursement purposes, when our patients are suffering this, a lot of times insurance gives them trouble with the drugs and things like that. So if it's in the NCCN guidelines, it helps for reimbursement. And so lo and behold, the new drugs are now there. Ruxolitinib, belumosudil, abatacept, they've all made it in there. So that's good for our patients. All right, so let's talk a little bit about some of these pivotal trials. The Rockstar study, it's such a cool name, right? But it's coming from the fact that the pathway is the Rho kinase inhibitor pathway. So this is the pathway that's blocked on the Rockstar study. It was a phase 2 study of belumosudil after patients had had 2 or more lines of systemic therapy. That means they had failed steroids, they failed something else, and then they got belumosudil. So these are people with pretty much severe GVHD, right? They're not responding to any other therapy, and then they got this drug. The primary endpoint was to look at overall response rate. In either they achieved a complete remission or a partial remission of, complete response, partial response. So it's an overall response rate. And then we're also looking at the duration of response, safety, something called the Lee symptom scale, which is almost like a patient-reported outcome to see how their symptoms have improved. Let the patient tell us that did their dry eyes get better and by how much. So that's the Lee symptom scale. Okay, so here it is. This is the study design. Again, there were pediatric patients involved, 12 years and over. These patients, again, as I mentioned, had very significant persistent chronic GVHD. And it wasn't really a drug trial that was looking at this drug compared to standard of care drugs. It was just looking at a dose finding, whether 200 milligrams per day versus 200 milligrams twice a day was better. So that was the study design. And here you could see that patients achieved a 74% overall response rate with the once-a-day dosing of 200 milligrams. And that met their primary endpoint. So this was approved at 1 year. And now we have updated 3-year follow-up. And even at the 3-year follow-up, the overall response rate is maintained, which is 74% for those who are getting once a day, 200 milligrams. So our patients don't need the twice-a-day drug, and they continue to have responses. So again, I know that this may seem like, look, the partial responders seem to be much more than the light green complete responses, but we have to remind ourselves that once people have steroid refractory GVHD, it's very hard to reverse. And we've achieved something if we achieve stability of the disease. We've achieved something if our patients are still alive, having good functional status, having good quality of life. And that's what we've done here on this study. It took about 4.4 weeks was the median time to respond. So again, as a reminder, these drugs don't act overnight like acute GVHD. Instead, chronic GVHD takes time to kick in. It's a slower process, and so it's a slower win. It was the median time from first response to initiation of any new systemic chronic GVHD was 100.3 weeks. Again, it's a length of time. And 63% of responses were between 4 to 8 weeks. So again, taking about 2 months to have that complete benefit. And 96% responses were observed by week 24, so even longer. So I think the takeaway is if you're on these drugs or you know somebody who's on these drugs and they're still not showing a whole lot of benefit by month 2, they probably still need to be on them because they could have late benefit. All right, so that was belumosudil. Now this is ruxolitinib. If you remember, I talked about ruxolitinib in acute GVHD. Now I'm talking about it in chronic GVHD. Again, this is a phase 3 trial. Super exciting to have phase 3 data. This is the REACH-3 study. Here again, ruxolitinib, it was randomized. It was 10 milligrams twice a day. It's a good, decent dose. Patients were allowed to be on steroids. Patients were allowed to be on anything else that they were taking for GVHD. And then they compared it to patients who were treated at physician discretion with whatever else was available to them without ruxolitinib. So that's a true randomization. The primary endpoint, again, was the same overall response rate, which is encompassing the complete responses and the partial responses at week 24 after starting therapy. And then they also looked at the symptom scale, the failure-free survival at week 24. So here you could see that patients who did develop, who got ruxolitinib compared to best available therapy, which is the BAT arm, had overall response rates of almost 50% compared to 25%. And this is at week 24, meeting the primary endpoint. On the right, the best overall response just through week 24 was much higher because these were capturing patients who at any given time had maximum benefit. And so that's why that's a bit higher. It was 76% compared to 60%. So that is why ruxolitinib is also now used and approved for chronic GVHD. All right, so then if you recall, we talked a little about macrophages. Macrophages was the cells that get activated in that third phase of chronic GVHD and essentially leaves fibrosis all around. And they are activated by a receptor called the CSF1 receptor. So it's but natural that we want to block that receptor. And so we have clinical trials using a drug called axatilimab. Which is a monoclonal antibody against the CSF1R receptor on the macrophages. So it blocks that. It also blocks something called interleukin 34, which also triggers the macrophage to get activated. And I'm only talking about macrophages in the bone marrow, but there are essentially macrophages, the same sort of pathway called microglial cells in the central nervous system. There are other cells in the bone marrow called dendritic cells, osteoclasts. And so this receptor can be found on all those cells. It is given by an IV administration and infusion. It's given every 2 to 4 weeks, so patients do need to remain on that. The Agave 201 study was where axatilimab was looked at in a dose-finding manner. Prior to this, there was the Syndax study, which also looked at axatilimab, but it was then taken over in this very larger phase 2 study. And they looked at this in the pediatric population, 2 years and older, even in adults. Patients had refractory, recurrent, active chronic GVHD. They had prior therapy with ruxolitinib, belumosudil, ibrutinib, all the standard drugs that we have now for chronic GVHD. And there was a lot of severity of chronic GVHD too. They were randomized in a 1:1:1 fashion because it was a 3-arm study. The lowest dose was 0.3 milligram per kilogram every 2 weeks. And then it was 1 milligram per kilogram every 2 weeks versus 3 milligram per kilogram every 4 weeks. So they were trying to do a higher dose, but spacing it out to every 4 weeks. And what it showed is that the primary endpoint, again, an overall response rate, was met within the first 6 cycles across all the dosing. But the best one was the lowest drug dosing, which is 0.3 milligram per kilogram given every 2 weeks. And this was really nice to see, because you don't want to give your patients higher doses if they don't need it, because every drug has some side effects. So on the left, you can see the dark blue bar is the lowest dose, 74% overall response rate compared to 67% and 50% at the other higher doses. And also regarding the Lee symptom scale, the secondary endpoint, meaning how many patients objectively tell you that they felt better or subjectively tell you that they felt better, was 55%. So there are a lot of trials that are ongoing right now to prevent graft versus host disease. Some of these are at multi-center, some of these are at single center, but everyone's still trying to find ways and nuances of doing transplants safer, even when there is disparity between the donor and recipient HLA typing, meaning how the degree of matching. When there's a higher degree of mismatching, there's more GVHD. So there are many different ways and trials that are exciting out there. This is not a comprehensive list, but some of the trials that I found interesting. And here are the clinical trials that are ongoing for frontline GVHD treatments. On the left are some of the belumosudil trials. When I say frontline, I mean we're trying to move away from steroids. We're trying to now have treatments that immune modulate rather than immune suppress completely. And so more and more clinical trials will come out trying to do things in a steroid-free zone, sparing the side effects of steroids on our patients. So this is trials with belumosudil and ruxolitinib that are coming more in frontline now. So all this is going to expand, I think, over the next 5 years, 10 years. We're going to have new indications. But I want to leave you with some other thoughts, right? So we can treat GVHD, we can prevent it, but transplant, as Dr. Hossein had mentioned, has a lot of side effects long-term, and that's survivorship. And there's damage to the tissues at a cellular level. There always destruction going on. So these tissues eventually lead to atherosclerosis sometimes in patients. They have premature cataracts. They can have coronary vascular disease, strokes, secondary cancers. They can have skin cancers. All of this requires a multidisciplinary team and an approach to treat our patients lifelong. And so I like to leave you with some next few slides of how we think about the BMT patient even after they've been transplanted. It doesn't stop there. You know, there's immediate transplant care. You've had wonderful talk on nutrition and diet today. You've heard some of the toxicities. You may have heard about relapse and how to treat relapse. But we also worry about the psychological health of our patients, but also our caregivers, right? And there's a lot of financial toxicity that our patients face that we sometimes are not doing a great enough job to help them with transportation, sometimes simple things like meals and even housing, helping them pay their rent. How do we get them going back to work in a safe environment so that they can be independent for themselves? So there's a lot of anxiety, depression, a lot of guilt that our patients feel because there's pressure put on their families. So they feel the burden of social isolation. We all felt this during COVID. So naturally, our patients feel this even more because they're vulnerable to the environment. And then not to forget how their caregivers also may feel anxious and have burden. So we do have a very specialized cancer survivorship care at Penn. We have social workers and psychosocial support team. Clearly, we have a very strong medical expert team. We are very quick to send our patients to pulmonologists, dermatologists, cardiologists who really want to focus on maintaining these patients' health and look at the secondary and late effects of transplant in these patients. We recognize they need dentists, so we're always in coordination with dental exams, the dietitian, because things like food and meals, sometimes if they have GVHD of the esophagus, it's hard to swallow. If they lose their teeth, they are dentulous, what kind of diet they can eat, that sort of thing. So here's what I like to think about, where This is a team-based approach. Together, everyone achieves more. That's the acronym I love about having a team-based approach. In the center of that team, the focal point is the patient and their interactions with the physician and the physician support team, which is the nurse practitioner or the physician assistant. But you know, this triad can't do it alone. We're supported by a vast administrative program that helps get our patients where they need to and get appointments. We have pre-transplant coordinators that Dr. Hossein also mentioned, you know, who help teach our patients about transplant, the side effects of transplant, and we have nurse educators. And then we have data and quality management because we want to make sure that we're doing a good job every single day. But we can't do this alone. And so the outer network, all of you, this conference that supports our patients, supports advocacy groups like that, really provide a peer support to our patients, give them more tools to look out for themselves and be advocates for their own health. Our patients need church, spiritual aid, temple aid, or things that, you know, faith-based practices are also important. Volunteers who want to support our patients and family members. All of this is what we need as a network to make it a successful transplant. So I'll leave you with some resources for our patients. On the top is, it's simple. It's if you go to the penmedicine.org website, you'll find a host of resources for patients, cancer survivors, and their caregivers. Some of this is also available. The BMT Infonet is an excellent website to go to for patients coming to transplant and their caregivers for information all about transplant, but also resources to connect with peers. Leukemia Lymphoma Society, you probably know that already, lls.org. For any fatigue wellness programs, the American Cancer Society, livestrong.org. And I want to leave you with this website, Stronger Through Cancer, mn.co. And the reason, because it's Philadelphia-based, it's a nationally accessible exercise program specifically for cancer patients and their survivors. I actually took a yoga class this past week, and I started talking with the yoga instructor only to learn that she teaches at Penn and does yoga with cancer patients. And it was a fabulous class. I enjoyed it thoroughly. So I don't get any commission or anything. I took it for myself. I loved it. So I want to share. Please visit the website. It is membership based. It has a small fee, but a lot of times insurance covers that fee. So you never know. And it has, you can even do this on Zoom. You can do it virtually. You can do engage with the larger community. So Stronger Through Cancer. And then there are resources for caregivers, because it's part of my research to also think about the relationship that our caregivers have with our patients and our patient outcomes. So I want to leave you with some things for our caregivers as well. And with that, I'm happy to take any questions. That's my email. So thank you for listening. Yeah, I thank you. And hopefully it didn't scare off anybody and in the audience virtually as well. Thank you for your time.
Thank you, Dr. Munshi, for sharing your time and expertise with us today. This session was recorded and it will be available on the AAMD-SIF website within 7 to 10 business days. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us these past day and a half and for making us your resource of choice for information on bone marrow failure diseases. The AAMD-SIF Medical Advisory Board and team are here to help you and your family, as we have been for the past 42 years. This concludes the conference. Safe travels home. Thank you.